Welcome once again to another clinical case presentation. I show that video because I'm proud to be here in Dallah. Today we are going to present another case presentation from level 4CD. Please pay attention and there will be surprises later. But to start it with, I would like to call on Ms. Dallah.
Good afternoon, everyone. Welcome to Dallah Al-Nakhil University College of Nursing, where people meet experiences in life. Today, we will tackle about how this hidden, creeping virus affects our life. Let's see if all of you have studied about herpes encephalitis. And today, let me remind you, this is our graded recitation. And as you all know, 2 weeks from now, it will be our final examination. And whoever of you can answer and discuss correctly will be exempted on the final examination. And of course, will have a gift from me. So are you all ready?
Yes.
I cannot hear you well. Are you all ready?
Yes.
Okay, so before anything else, I would like to discuss with you our objectives. First is to be able to identify what is herpes encephalitis and its clinical manifestation. Second, to discuss the pathophysiology of herpes encephalitis. Third, to describe the diagnostic test required for herpes encephalitis and explain the medical and nursing management provided to patients with herpes encephalitis. So hepatic infections have plagued humanity for thousands of years, but only recently have advances in an antiviral medication and supportive treatment equipped physicians to combat the most severe manifestation of disease. Prompt recognition and treatment can be life-saving in the care of patients with herpes simplex 1 virus encephalitis, which is the most commonly identified cause of sporadic encephalitis worldwide. Clinicians should be able to identify the clinical signs and symptoms of the infection and to familiarize themselves with a rational diagnostic approach and therapeutic modalities, as these are the keys for improving better outcomes. So as you all know, herpetic infections have been recognized since the time of ancient Greeks, and the word herpes translates as creeping or crawling and is a reference to herpetic skin lesion. Good Pasteur and others demonstrated the material from the herpetic lip and skin lesion produced encephalitis when introduced into a scarified cornea or in the skin of rabbits. In the year 1920, the Madison Commission was among the earliest reports to suggest HSV caused encephalitis in humans. The first ever pediatric case report of HSV was published in the year 1941, and the first ever adult case was a 25-year-old man presented with headache, fever, aphasia, left pupillary dilatation, and this was reported in the year 1944. Okay, so now that I've done my part, let's see how well you've researched about this disease condition. So I have here the flashcards with me that contains all the names of the students coming from freshman, sophomore, junior, and senior team. So mind you, student, later on there will be a twist. So if I were you, you have to listen very carefully and prepare yourself. Okay, so let me start with the sophomore team. From the sophomore team, may I call on Miss Trashara Luce. Miss Trashara Luce, could you please tell us more about herpes encephalitis and what are the signs and symptoms of this disease?
Good afternoon, guys. So, what is herpes encephalitis? Herpes encephalitis, it is a viral encephalitis that which happen when herpes simplex virus enters to the brain. It can be acute or subacute illness that may affect both general and focal signs of cerebral dysfunction. It is estimated at least 1 to 500,000 individuals per year, and there's some studies of 5.9 cases per 100,000 live births. It usually occurs during early childhood and affect both males and females with equal numbers. In symptoms associated with herpes encephalitis, it's developed over several days, or there's no warning signs. In early symptoms include fever, headache, and seizure. Other symptoms include drowsiness, generalized weakness, confusion, and disorientation. When symptoms occur, the patient may experience speech abnormalities, such as inability to communicate by speech, writing, or signs of aphasia. It can be diminished sense of smell or memory loss. In other cases, behavioral changes may occur, such as hyperactivity and psychotic episodes. Yes. And then, did you know that herpes encephalitis can mimic the symptoms of meningitis, including stiffness, altered reflexes, confusion, convulsion, and paralysis? So what is the cause? It is the infection by herpes simplex virus. The disease caused by herpes simplex virus 1, and in rare cases, like newborn or neonatal, the disease caused by herpes simplex virus 2.
Okay, Mr. Luce, I have heard that you have a patient with herpes encephalitis. Could you please tell us more about that patient of yours?
Yes, ma'am. My case was a 58-year-old female patient with known history of peptic ulcer disease, chronic gastritis, and past surgical history of hysterectomy, presented to ER with 3 days on and off fever, generalized weakness, and headache, with 2 days altered level of consciousness and disorientation. The vital signs are 140/70 of BP, pulse rate of 98, respiratory rate of 22, and temperature of 38. Upon assessing of medical residents, the patient was disoriented to time, place, and person, with sluggish response to command, and she was positive stiffness, but there is no weakness. Series of investigation was done, including CT scan, abdominal ultrasound, and MRI of brain. In MRI of brain, the result was encephalitis, most likely herpes encephalitis. Lumbar puncture was the procedure of choice. CSF was sent for analysis. They ordered to do EEG, antiviral therapy, and antibiotic was started. She was referred to Dr. Mazenbari, our infectious disease doctor, and ordered antiviral for 21 days. But unfortunately, the patient was, and he ordered series of investigation to confirm the diagnosis. But unfortunately, the patient was positive in herpes encephalitis. Upon the course of treatment, the patient was complaining of headache. They ordered to repeat MRI, but still the result was no comparison between first MRI. They ordered to repeat lumbar puncture. The result was increase of WBC, leukocytes, and protein. That's the time Dr. Mazenbari reviewed again the patient and ordered to continue acyclovir 750 milligram IV every 8 hours for 14 more days. The patient was improved and ordered to repeat HSV1 PCR, and the result was negative. The patient was discharged from the last dose of acyclovir. Thank you.
Thank you very much, Mr. Luce from the sophomore team. Now, let us move on to our next topic, which is the anatomy and physiology. May I call on from the freshman team, Mr. John Kenny. Mr. John Kenny, could you please tell us briefly about the anatomy and physiology of the brain? But I wanted to focus more on the cranial nerves.
Thank you so much, ma'am. Good afternoon. When we say herpes encephalitis, the main affected part is the brain. And brain is basically defined as one of the largest and most complex human organ in the body. And it has 3 major parts. the cerebrum, the cerebellum, and the brainstem. Cerebrum is responsible for remembering, problem solving, thinking, and feeling, while the cerebellum is responsible for coordination and balance. Brainstem is responsible for making all of us alive. Why? Because the major function of the brainstem is breathing, digestion of food, and blood circulation. And brainstem is divided into 3 levels, which is the midbrain, the pons, and the medulla. There are 12 pairs of cranial nerve that originate from the brain and brainstems. And the cranial nerve is directly emerged from the brain, including the brainstem, while the spinal nerve is directly emerged from the segment of the spinal column. And each cranial nerve has different functions in related to the senses of our body. The cranial nerve is paired and present on both sides. The numbering of the cranial nerve is based on which they emerge from front to back. The terminal, the olfactory, and the optic nerve is directly emerged from the cerebrum, while the 10 remaining pairs of the cranial nerves arise from the brainstem, which is the lower part of the brain. The cranial nerve is considered component of the peripheral nervous system. However, in the structural level, the terminal, olfactory, and the optic nerve is considered more accurate component of the central nervous system. And now, let us discuss the cranial nerves and its locations in the brain. The cranial nerves number 1 and 2 is located in the anterior brain. The cranial nerve number 3 and 4 is located in the midbrain. Cranial nerve number 5, 6, 7, and 8 is located in the pons. Cranial nerve 9, 10, 11, and 12 is located in the medulla. And now let us discuss the 12 pairs of the cranial nerves and their functions. Cranial nerve number 1 is the olfactory nerve. Olfactory nerve is responsible for the sense of smell, but this is one of the few nerves that is capable of regeneration. Cranial nerve number 2 is the optic nerve. The optic nerve, it carries visual information from retina of the eye to the brain. Cranial nerve number 3, the oculomotor. The oculomotor nerve is responsible for the movement of the eye, constriction of pupil, and maintaining the eyelid open. Cranial nerve number 4 is the trochlear nerve. The trochlear nerve is responsible for the rotational movement of the eye. Cranial nerve number 5, the trigeminal nerve. The trigeminal nerve is responsible for the control of the muscle of the face and mouth. Cranial nerve number 6 is the abducens. The abducens nerve is responsible for the lateral movement of the eye. Cranial nerve number 7, the facial nerve. The facial nerve is responsible for the sensation of facial expression, production of tears and taste. Cranial nerve number 8, the vestibulocochlear. The vestibulocochlear nerve is responsible for the transmission of sounds and balance, or the equilibrium, from the middle ear to the outer ear. Cranial nerve number 9, the glossopharyngeal nerve. The glossopharyngeal nerve is also responsible for swallowing and secretion of saliva, but it can also monitor the blood pressure, the oxygen level, and the carbon dioxide level in the blood. Number 10, the vagus nerve. The vagus nerve is responsible for the control of the PNS. And the PNS are the smooth muscle of the lungs, heart, and the GI tract, or the peristalsis. Cranial nerve number 11, the spinal accessory. The spinal accessory nerve is responsible for the specific muscle movement in our shoulder and in our neck. Cranial nerve number 12, the hypoglossal nerve. The hypoglossal nerve is responsible for the speech, food manipulation, swallowing. And before we end this topic, I would like to give you some tips on how to remember or memorize the 12 pairs of the cranial nerves with the use of the mnemonics. For the cranial nerves, we will use the on old Olympus tower taps and Finn and German viewed some hops. And for the functions, some say mere money, but my brother says bad business makes money. Where S stands for the sensory, M stands for the motor, and P stands for both sensory and both motor. And that will be all for the anatomy and physiology of the human brain.
Thank you very much, Mr. John Kenny from the freshman group. Thank you for giving us this information about the brain and moreover for discussing about the 12 cranial nerves. So now, let us move on to the question and answer. This is the twist. I know all of you are wondering what it is. Okay, so I will give you the mechanics. As you can see, there are balloons. Some chairs contains balloons. That means when you are facing that balloon, you belong to that group. Like for example, on the first row, the colored balloon is green. That means you belong to the freshman group. And the one facing the yellow balloon, that means you belong to the sophomore group. And so on and so forth. So you get it?
Got it.
Got it? Okay. Now I would like to ask question from the senior group. Could you please raise your hand, senior group? The senior group is the one that the balloon, they are facing the blue balloon. The blue balloon. Who's facing the blue balloon? Okay, so that means you belong to the senior group. Okay, I will instruct you. Listen very carefully. That balloon contains the question. There is a paper attached to it. The one that's facing that blue balloon, could you please pick it up and open the paper that's attached to it? Now, yeah, open. Who among you guys got the question? Could you please stand up?
Stand up.
Could you please stand up so that you may be recognized? Where are you? Okay. Hello, ma'am. Good afternoon. You have read the question. I will go there. Could you please read the question and you can answer at the same time?
What are the 12 cranial nerves?
Simon.
The 12 cranial nerves. The first
Simon.
one is
Simon.
olfactory, optic, oculomotor, cochlear, trigeminal, of the sense, facial, acoustic or vestibulocochlear, glosopharyngeal, vagus, spinal accessory, and hypoglossal.
Simon.
Very well said. Oh, isn't it that I mentioned before, there's a gift, so you have a gift. Okay, later on, we'll give it to you. Okay, after we've done about this, we've already discussed about the anatomy and physiology of the brain and the cranial nerves. Now let us move on to the pathophysiology of herpes encephalitis. In order for us to further understand this particular disease condition, I would like to call on from the senior group. Oh, we have a volunteer from the senior group. May I know your good name, please? Miss Maricel Navarro from the senior group. Could you please tell us about the pathophysiology of herpes encephalitis?
Good afternoon. When we're talking about the pathophysiology of the disease, we're trying to figure out how that disease causing symptoms. So in the case of herpes encephalitis, I will track on how the virus infects the central nervous system and causes symptoms. Encephalitis is an acute inflammation or swelling of the brain. The majority of cases occurs either by viral infection or the immune system mistakenly attacking the brain tissues. In rare cases, it can also be caused by bacteria, like tuberculosis and syphilis. It can also be caused by fungi, like Aspergillus and Candida, and perhaps parasites, like roundworms and toxoplasmosis. This condition mostly affects elderly, children, and adults with compromised immune system. Viral infections include herpes simplex virus 1, herpes simplex virus 2, varicella zoster virus, Epstein-Barr virus, measles, and mumps. But the most common among all of this is the herpes simplex virus. So, to better understand herpes encephalitis, I will start on how the virus enters the human body. As I go on with my presentation, I will make some illustration, guys. So please bear with me because I'm really not good in it. Herpes simplex virus mostly cause mucocutaneous disease, meaning it affects the mucous membrane of the skin, and specifically in the oral cavity, and classified as type 1. So, how this has happened? First, in primary infection, the virus enters the epithelial cell or any abraded or damaged epithelium, and that causes the lesions that we see. But it doesn't stop there, because HSV is a neurotropic virus, meaning a virus that can infect the nerve cells. Neuroinvasive, capable of accessing the central nervous system and causes disease. And since they love neurons, the virus is actually taken up by the sensory neuron, and it undergoes retrograde transport into the sensory ganglia, and that's the cell body, and that is where the latent infection usually established, when the epithelial cell infection stopped by the immune system. So technically, the HSV is still hiding out in the sensory ganglia. Then in some point, in some neuron, the virus reactivates and starts replication, and it infects the epithelial cell again via the interrograde fashion, and lesions form again. And that is what we call recurrent or reactivated infection. Please take note, guys, that HSV is good in establishing latent infection in the olfactory and trigeminal nerve. When we say latent infection, it is the type of infection that is hidden, inactive, or dormant, however, potentially causing disease in the future. According to studies, it turns out that herpes encephalitis can happen in either case, be it primary or recurrent infection. And you don't need to have the mucocutaneous disease in order for you to develop the herpes encephalitis. So, how does the virus infect the central nervous system? Well, this is interesting. Well, the way it gets into the brain, the virus was diverted into another direction. Remember the nerves that I talked about, the olfactory and trigeminal. So from those pathway, which is the neural pathway, the virus gets into the CNS. And what will happen then? This will lead to meningoencephalitis and encephalitis. Both causes hemorrhagic necrosis. So, because of the hemorrhage, it is common to see RBC
in addition to WBC and lymphocytes and cerebrospinal fluid in lumbar puncture. Other procedures to be done is the PCR and CSF for HSV, which has excellent sensitivity and specificity. So how does the patient present with herpes encephalitis? Well, people with herpes encephalitis presents pretty acutely within a week of developing symptoms. The symptoms are fever, headache, and vomiting. This vomiting is due to the increased intracranial pressure. And remember, this is encephalitis, so focal neurological signs and symptoms are present as well. How does HSV encephalitis differentiates or distinguished from any viral cause? Well, there are a few key things to remember. Generally, first, it's severe. Severe because HSV is unlikely gets into the brain. So when it does, it causes very severe disease. So 70% of people with HSE will die without treatment. And even with treatment, 20% of people will still die. So this is why, if you ever think that herpes encephalitis is even a possibility, start the treatment right away with a cyclone. Other treatments include giving corticosteroids, analgesia, and anticonvulsants. And something else that differentiates herpes encephalitis from other viral causes, it's target the temporal lobe of the brain. And it can be seen in the images like MRI. And you might as well remember the pathway, the neural pathway I've mentioned earlier, the olfactory and trigeminal. So when the virus enters in the brain, it is spread into the temporal lobe. And remember, guys, that our temporal lobe governs our emotions and our memory. So damage to them will result to bizarre behavior, like manic symptoms, confusions, hallucinations, and amnesia. Some people will manifest anosmia, language impairment, and visual field deficit. And on top of this, when worst comes to worst, some patient will manifest seizures and coma. And that ends the pathophysiology of herpes encephalitis.
Thank you very much from the senior group, Ms. Maricel Navale. So now that we know how this creeping virus diverted its trail, now let us proceed with the question and answer portion again. I know that you're excited about this. So now, I would like to address this question to the freshman group, the one that's facing the green balloon. The green balloon. Okay. Yeah, that line, but I think there's no button. Okay, could you please pick up the balloon and please read the paper that's attached to it?
Thank you.
So, could you please stand up? Oh, okay. You are so lucky. Could you please read the question and answer at the same time?
So, what are the two cranial nerves involved in herpes encephalitis? So, number one is trigeminal and olfactory.
Correct. That means you're listening very carefully with the pathophysiology. Okay, so now let us proceed to the diagnostic and procedures being done to the patient with herpes encephalitis. So now may I call on from the junior group. Oh, we have another volunteer from the junior group. May I know your good name, please?
Good afternoon, ma'am. I'm Joanna Rodriguez from Virginia.
Could you please come to the stage? Thank you, Ms. Joanna. Could you please tell us more the diagnostic and procedures for the patient with herpes encephalitis?
Good afternoon once again. In patients with suspected herpes simplex encephalitis, the workup should be initiated rapidly and should not delay treatment. During early stages, when treatment would be most effective, the symptoms can be very general, so there may be several possible diagnoses. Also considering the fact that there is no pathognomonic clinical findings associated with herpes simplex encephalitis, but also importantly, to exclude other conditions. Brain imaging by computerized tomography or CT scan can be done, though on CT scanning, focal neurologic deficits and cerebrospinal fluid pleocytosis and abnormalities may be absent initially. Brain CT may show changes in the temporal lobe or frontal lobe. Low-density lesions may be found, 2/3 of cases, especially in the temporal lobe. But this may not appear 3 to 4 days after onset. Edema and hemorrhages may be present at this time. On the other hand, magnetic resonance imaging of the brain is the preferred imaging study for herpes simplex encephalitis. Sometimes, an electroencephalogram is done to monitor brain electrical activity, assist diagnosis. Though it's lacking specificity, it has 84% sensitivity to abnormal patterns of herpes simplex encephalitis. These procedures, together with careful and continuous clinical assessment, provide data which may be suggestive of herpes simplex encephalitis. The key diagnostic procedure is a lumbar puncture. This procedure takes some fluid bathing the brain and the spinal cord or the cerebrospinal fluid for laboratory analysis, which then should be sent for herpes simplex virus 1 and herpes simplex virus 2 polymerase chain reaction or PCR study. PCR analysis has virtually replaced brain biopsy as the criterion standard for diagnosis. It is highly sensitive and specific, and results usually become positive 24 hours after the onset of symptoms and remains positive after at least 5 to 7 days after the start of antiviral therapy. So in the case of our patient, she had undergone a series of diagnostics and procedures, first of which is the CT brain.